The abdominal exam requires both patience and practice and a comfortable patient. So we'll position the patient lying on his back. And it's oftentimes very useful to put a pillow underneath his knees to help relax the abdominal muscles. This just makes it easier to palpate through the abdominal musculature, particularly in young men. We expose the abdomen up to about the nipple line and then down to the symphysis pubis. We're going to examine the abdomen using all four of our methods. We're going to inspect, and then we're going to listen or auscultate. We will percuss the abdomen, and then we're going to do palpation. It's very important to have a three-dimensional view of the abdomen, know what you're looking for. The abdomen is sort of the black box of medicine because we don't have the ability to see into the gutters, so we have to create that view. So the abdomen is defined superiorly by the diaphragm, which sits at about this level. The liver sits in the right upper quadrant, attached to the underedge of the diaphragm. The spleen sits in the left upper quadrant, actually very posteriorly in about this area. The stomach sits under the left lower chest. The kidneys are both very deep in the upper quadrants, in the gutters back here. And then the bowel, which runs from the cecum in the right lower quadrant, ascending colon, transverse colon, splenic flexure, descending colon, and then the sigmoid colon will oftentimes be palpated in the left lower quadrant to midline. The bladder sits actually in the pelvis, but when enlarged, may enlarge out of the bladder, and in women, of course, the uterus, enlarged for whatever reason, pregnancy, fibroid tumors, or whatever, will enlarge out. Occasionally, we'll see very large ovarian cysts move up out of the pelvis into the midline or the lower quadrants. So when you inspect, you want to look at the normal contours, the costal margins on either side. A little dip here in thin people, and this is important to look for because if this fills in, then it suggests that there's enlargement perhaps of the liver in this area. The abdomen is nice and flat, and we see no abnormal bulges. It's oftentimes useful to examine also from the side and the foot of the bed, getting down low, and in that position you can see any abnormal bulges. You may also be able to see the pulsation of the abdominal aorta and the epigastrium, which is normal in thin people. Can I have you lift your chin to your chest? So by doing this maneuver, we're increasing the intra-abdominal pressure. Go ahead and put your head back. And this will oftentimes expose hernias in the anterior abdominal wall that may be completely invisible otherwise. Another method of doing that is to do a Valsalva maneuver. Would like you to take a deep breath, hold it in, and bear down like you're having a bowel movement. Okay, and you can see the abdomen bulge up, indicating the diaphragm is lower, the intra-abdominal pressure is up. Go ahead and relax. But we don't see any abnormal bulging or protrusion of intra-abdominal structures through the abdominal wall, which would be an abdominal hernia. So next, we're going to auscultate. I auscultate starting with the bell and the epigastrium, and then move systematically across the abdomen. We're listening for bowel sounds as well as for sounds of abnormal blood flow, either in the aorta in this area. Remember, the bifurcation of the aorta is about the level of the umbilicus. On either side over the great vessels as they move down to the femoral arteries. And it's important to auscultate over the femoral arteries at the same time. Good. So no bruits and normal bowel sounds. Next, we're going to percuss. And we use definitive percussion to try and outline the borders of the liver. The superior border of the liver can be estimated where the percussion note moves from the resonance of the chest to a dull note, indicating that the liver is sitting underneath that part of the abdomen. We can also try to percuss the lower border of the liver, and again a transition in his case right about at the costal margin. Another way of locating the lower edge of the liver is called the scratch sign, and you can do this by listening over the lower ribs and scratching the abdomen. And where you hear a distinct change in the sound, that's generally an estimate of the liver size, or the lower liver edge. None of these are particularly accurate, but you can get a ballpark figure for liver size. Percuss over the lower rib cage on the left from the infrasternal notch. If you go straight laterally and then along the lower left ribs, this forms a triangle that's called Traub's space. Normally, percussing in that triangle will produce a tympanitic or hyperresonant note indicating the gastric air bubble, which sits right underneath this area. If you get dullness in that area, it suggests perhaps the spleen is enlarged, moving in this direction, or there may be stool in a colon that slipped up in front of the stomach. The other areas in the abdomen, the percussion note is a flat note indicating that there's no air that we're getting there. Percuss in the suprapubic area. Sometimes you'll be able to percuss out the border of an enlarged bladder in this area. Next, we're going to palpate the abdomen, and we use two forms of palpation. We use superficial palpation and deep palpation. For superficial palpation, I use the whole flat of my palm and fingers and glide it over the abdominal wall, pushing in about 1 centimeter and moving the soft tissues of the abdominal wall over the parietal peritoneum and trying to feel any edges you might come across. Edge of the liver, edge of a mass. Sometimes you'll feel soft masses that you can sort of push out of the way. You may not be able to feel those when you do deep palpation. I liken this to trying to feel a dime under a tablecloth where you'd rub your hand across and catch that edge, feel that edge. Okay. Don't forget to palpate right under the umbilicus as well. Next, we're going to do deep palpation. I do that bimanually, feeling with my right hand, pushing with my left hand. That keeps the muscles in my right hand and the tendons relaxed so I can feel more easily. We're going to push in gently. Don't be sudden because the patient will guard if you do that. Start in the epigastrium and just gentle, deep palpation. I can easily feel the aorta right here. That's normal. Is that a little tender? Okay. So it's useful to watch the patient's face while you're palpating deeply. If you elicit pain, the patient will often express that more by their facial expression than verbally. Any tenderness there? Okay. So I'm over the descending colon. I can feel a little bit of stool here in the sigmoid colon. Tenderness there. Deep in the suprapubic area, this is where you would feel an enlarged bladder or gravid uterus. The right lower quadrant, classically McBurney's point, where the classic location for acute appendicitis. Frequently you'll feel the cecum and stool in the cecum, and I can feel that right here in the right lower quadrant. Is that painful? Nope. Uncomfortable? Good. All right. So systematic deep palpation, and again, don't forget to palpate right down under the umbilicus. Remember that about 3 centimeters below the umbilicus, the lumbosacral junction protrudes up into the abdomen. You'll frequently feel that in thin people, may be mistaken for a mass. Remember that the lumbar spine runs right down the middle of the abdomen, forming a ridge in the middle, and that the kidneys lie deep in either gutter. Very hard to feel even a very enlarged kidney. Next, we're going to feel for the liver. Now, the liver takes a lot of practice, and the idea is to bring the liver down to the examining finger. Remember, the liver is attached to the underside of the diaphragm, so when a patient takes a deep breath, the diaphragm descends, bringing the liver down with it and into the palpating hand. So what we're going to try to do is encourage that by lifting underneath the posterior chest, asking the patient to take a deep breath in, blow it out. As he blows out, I push in and then take a deep breath. And as he breathes in, I raise my fingers and catch that liver edge as it comes down. A common mistake is to start too high, like I did that time. Take a deep breath, blow out, big breath. It's a good idea, blow out, to start low in the abdomen, big breath. It's good, relax. It's not uncommon in a very enlarged liver for the liver edge to be quite low in the abdomen. If you start too high, you'll be on top of the liver and not catch the edge. To feel for the spleen, we use the same concept. That is to try to bring the spleen towards our examining hand by compressing the lower chest and then having the patient take a deep breath so the spleen descends towards our hand. When the spleen enlarges, it enlarges towards the umbilicus in this direction. So take a deep breath, blow out, 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 out. Pull with your left hand, big breath. Good, relax. It's necessary to keep pretty firm pressure there. As he breathes in, your hand can't move in order for that spleen to come down. Another way to look for the spleen is to have the patient roll on his right side. Put this hand just behind you there. And then we're basically going to do the same thing. I'm going to compress with my left hand and then palpate with my right. Big breath. Blow it out. Big breath. Good. Go ahead and roll back. Remember, the spleen has to be really quite enlarged before you're going to be able to feel it. Lastly, we want to be sure to palpate both femoral arteries. As they exit the abdomen under the inguinal ligament. All right. So that concludes the abdominal examination. The abdominal exam requires a lot of practice. It takes actually several years for many physicians to be able to reliably detect the liver edge in a normal patient. But I encourage you to practice with each and every patient that you examine and every opportunity you get. That's the only way to become skilled at this very important examination.